Hello and welcome to our new topic. Today we are entering one of the most clinically demanding areas of pharmacology, prescribing in the elderly. Geriatric pharmacology is not simply adult pharmacology with lower doses. It is a fundamentally different therapeutic environment shaped by physiological decline, altered homeostasis, multimorbidity, and polypharmacy. As life expectancy increases globally, older adults represent a rapidly growing proportion of our patients. Yet they remain underrepresented in clinical trials. This creates a paradox. We prescribe extensively in a population where evidence is often extrapolated. Our goal today is not just to memorize changes, but to understand how aging alters pharmacokinetics, pharmacodynamics, and risk profiles, and how we can prescribe safely and rationally. Let's start. The learning objectives are shown. Please take a look. By the end of this session, you should be able to: first, describe the various physiological and pathological factors that influence drug effects in elderly patients. This includes understanding how aging modifies absorption, distribution, metabolism, and excretion. Second, apply principles of rational drug therapy in older adults, not just identifying risk, but practicing judicious prescribing. Keep in mind that geriatric pharmacology is about balancing benefit with fragility. Aging brings predictable biological changes that directly influence drug behavior. First, less total body water and muscle mass. This reduces the volume of distribution for water-soluble drugs such as gentamicin. As a result, serum concentrations rise more quickly. Second, more body fat, which could be relative due to lower muscle mass or absolute due to gaining weight. Lipophilic drugs like diazepam accumulate in fat, prolonging half-life and increasing sedation risk. Third, slowed hepatic metabolism, especially phase 1 reactions mediated by cytochrome P450 enzymes. Drugs such as benzodiazepines and certain beta blockers may have prolonged effects. Fourth, decreased renal excretion. Glomerular filtration rate declines progressively after age 40. Drugs such as digoxin, lithium, and metformin may accumulate. Finally, reduced baroreceptor sensitivity. This explains why elderly patients are prone to orthostatic hypotension when given antihypertensives. The key message: aging reduces physiologic reserve. Older adults rarely present with a single disease. They have multiple chronic illnesses: hypertension, diabetes, osteoarthritis, ischemic heart disease. This leads to polypharmacy, often prescribed by different specialists. Drug interactions multiply exponentially. Adherence becomes an issue due to cognitive decline, complex regimens, cost, visual impairment, etc. Additionally, elderly patients frequently use OTC drugs and herbal supplements. For example, NSAIDs for pain, ginkgo biloba with anticoagulants, St. John's wort affecting cytochrome P450 enzymes. So prescribing in elderly is a systems problem, not just a pharmacology problem. Absorption is generally preserved with age, but comorbidities may alter it. For example, lack of intrinsic factor reduces B12 absorption. Delayed gastric emptying alters onset of action. Distribution changes are more clinically significant. Lower serum albumin increases free fraction of highly protein-bound drugs like warfarin and phenytoin, leading to dose-dependent adverse effects. Reduced total body water increases plasma levels of water-soluble drugs. Increased body fat prolongs half-life of lipophilic drugs with important consequences. For example, an elderly patient given diazepam for sleep may experience daytime sedation and hangover for days. Hepatic size and blood flow decline with age. Hence, phase 1 metabolism, oxidation, reduction, hydrolysis tends to decrease. Polypharmacy further increases metabolic interactions. For example, an elderly patient on warfarin and amiodarone may develop bleeding due to cytochrome P450 enzyme inhibition. However, phase 2, conjugation reactions are relatively preserved. This is why drugs metabolized via phase 2, such as lorazepam and oxazepam, are preferred benzodiazepines in elderly. renal clearance declines progressively. It is important to note that serum creatinine may still appear normal due to reduced muscle mass, but true GFR may be significantly decreased. Therefore, creatinine clearance must be estimated using formulas such as Cockcroft-Gault equation, which is even better than estimating eGFR. Some examples of drugs that require dose adjustment include aminoglycosides, metformin, digoxin, anticoagulants. Failure to adjust doses is a major cause of adverse drug events. Comorbidities alter pharmacology further. For example, GI disease reduces absorption. Liver disease reduces metabolism. Kidney disease reduces clearance. Cardiac failure reduces hepatic perfusion, impairing metabolism. In addition, neurological disease increases sensitivity to CNS drugs, such as Parkinson's patients may experience severe confusion with anticholinergic drugs. Thus, the key message is that comorbidity amplifies pharmacodynamic variability and physicians should be aware of it. This slide clarifies terminology which matters for clinical reporting and pharmacovigilance. There are three terms discussed here. Adverse drug effect occurs at normal doses and is predictable. Adverse drug reaction may occur at any dose and may not always be predictable. Adverse drug event is the broadest category, includes medication errors along with the adverse events and reactions. In elderly patients, ADS are common due to prescribing errors, monitoring failures, and polypharmacy. Adverse drug events are a leading cause of hospital admissions in elderly. The ADE risk increases with following conditions existing individually or combined: more than 6 chronic diseases, more than 9 medications, more than 12 doses per day, age above 85, low BMI, and reduced creatinine clearance. Notice that many errors occur at ordering and monitoring stages. Hence, prevention requires a stringent medication review and dose adjustment. More than 2/3 of ADS in elderly are caused by anticoagulants, antithrombotics, diabetes agents, insulin, sulfonylureas, and opioid analgesics. These drugs have narrow therapeutic indices or cause life-threatening hypoglycemia, bleeding, or sedation. NSAIDs contribute through renal failure and GI bleeding. Antibiotics may cause renal toxicity or C. difficile infection. The key concept here is high-risk drugs plus fragile physiology equals hospital admission. Judicious prescribing begins with clear therapeutic endpoints. Always ask, what is the goal? Symptom relief? Mortality reduction? Quality of life? Be clear in that. Start low and titrate slowly. Avoid therapeutic duplication. Avoid prescribing a drug to treat side effects of another drug. Consider renal and hepatic function. Simplify regimen. De-prescribing is as important as prescribing. The safest drug in elderly is often the drug not prescribed. Thus, the take-home message would be that the geriatric pharmacology is dynamic and evidence-based. Continuous review of updated literature is necessary. A clinician's responsibility is not only to treat disease but to prevent harm. In elderly patients, therapeutic success is measured not only by biochemical correction but by preservation of function, cognition, and dignity. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!